Yeah, so good afternoon or good morning. I think it's still morning there in California. I'm going to be giving you the second half of the psychiatric and sleep disorder lecture this morning. So, yeah, we covered a lot this morning in the first half, and hope you guys got a lot out of it. I think TCM is involved a lot with psychiatric disorders and sleep. I mean, a lot of the 10 questions we ask, is involving sleep. We ask a variety of different questions with sleep. And also with psychiatric disorders, we use the 8 extraordinary meridians. We do external dragon treatments. We help these people out. We help them calm down. We're able to access them in different ways instead of using these psychiatric drugs and these SSRIs and multitude of drugs that are being utilized for people with a lot of disorders, and with it comes a lot of medications. So there's a lot of side effects. We should caution our patients not to take so many. Some of them actually need it, but I think that what comes with that is a lot of caution. Okay, so this is what we covered so far. We talked a lot about these different issues, and let me go ahead and start it. Okay, so we talked about psychiatric assessment this morning, medical assessment, diagnosis, different types of behavioral emergencies, and legal aspects in regards to the 5150. That's the Welfare and Institutions Code that we can use. Cognitive behavioral therapy and anxiety. We talked about different types of anxiety, obsessive compulsive disorder, panic attacks, and phobias. And for the rest of this lecture, we're going to cover eating disorders, which include anorexia nervosa, bulimia. We're going to talk about major depression, bipolar, schizophrenia, suicidal behavior, insomnia, and snoring, and also obstructive sleep apnea. And what's funny that these sleep disorders are mixed in with the psychiatric lecture, right? I imagine if the first thing that captors do is if they capture like a diplomat or something like that, or prisoner of war, one of the interrogation techniques is to you know provide sleep deprivation, which drives them nuts, right? If you don't get any sleep and you're pressured and you have to keep working and you're preventing this person from going to sleep, this person is actually going to slip into any type. They're going to have a meltdown. So, it kind of makes sense that it's paired in with that. So, eating disorders, okay, they're grouped into 3 categories: anorexia nervosa, bulimia nervosa, and eating disorder not otherwise specified. So, they're not able to determine in the DSM-4 or 5, it doesn't really fit that category. So, but they do have an eating disorder. So maybe they should come up with another word. Anorexia nervosa. So it's a relentless pursuit of thinness, morbid fear, right? This is our Karen Carpenter. A lot of Hollywood stars fall into this. They're pressured to lose a lot of weight. Every commercial out there shows this thin woman, these thin models walking down the runway, and everyone thinks that's normal. So it's a lot of peer pressure. Hopefully, we can stop this insanity, with the stereotypes of, that's a normal. So there may be some endocrine abnormalities, low luteinizing hormone, low thyroid hormone, increased cortisol, and dehydration and metabolic alkalosis may occur. So also cardiac muscle mass, may change, the chamber size and output may decrease. Signs and symptoms. Most patients are lean, yet concerned about body weight and restrict food intake. So they have that preoccupation with food that manifests as, by studying diets and getting into these fad diets, and they kind of lie about, their food intake, and they act like it's normal for them, where they're out there obsessively exercising and trying to lose weight, and and they're already thin, but they have this obsession about it. So they diagnose it by clinical criteria, and usually a family member gets concerned, and they bring them in, they talk them into it, kind of like have a come to Jesus meeting and say, hey, there's something wrong. We care for you. We need to do something about this. So there's always that denial of illness with anorexia. The way they treat it, sometimes they have to feed them by nasogastric tube, and they got to get nutritionists involved. They take a look at their blood work, see what's going on, what kind of vitamin and mineral deficiencies they have. Long-term outpatient treatment after nutritional fluid and electrolyte status has been stabilized, right? So they want to look at their they want to treat it with cognitive behavioral therapy over a 1-year period, and family therapy that does not assign blame to the family or patient. Yeah, that really happens. Every psychotherapist, at least, what I've seen, only takes 2 years to be a psychotherapist, right? You guys go to school for 4 or 5 years. Where they get good at is, the patient contacts. They get several patient contacts, and that's where their clinical experience. But, these people, they send them to school for 2 years. Next thing you know, they're out there, treating, these disorders that are very complicated, using, theories from Freud and everyone else, and, Carl Jung, and, they come up with these therapies, and, I think acupuncture can do a really good job for all of these disorders. And these are all related, or a lot of them are related to some type of past traumas, right? So, and the treatment can be complicated by aberrance of weight gain, denial, and manipulative behavior. So, bulimia nervosa, something else, right? It's characterized by recurrent episodes of binge eating. And these people eat so much and they purge, and they go into fasting, and are driven by exercise occurring at least 2 times a week for 3 months. So there's serious fluid and electrolyte disturbances that happen as a result, because when they purge, they're getting rid of everything. They actually have substantial weight loss that doesn't occur like anorexia, but it can. And nutritional deficiencies are not present. But they release so much acid every time they purge, it actually messes with the tooth enamel. And, they'll hide little barf bags all over the place, all over the house, and then they'll dump it, after it gets stored up. I've seen a couple of shows on this where this lady was just hiding her barf, all over the place. Not a pretty sight, right? So this is something that needs to be addressed. And usually they have binge purge behavior, and they have rapid consumption of amount of food larger than what most people can eat that normally would eat. And they feel like they're out of control. It's kind of like having an addiction, right? Where they're a heroin addict and they're still conscious of they just want to get high. This is kind of the same thing, same kind of feeling. And then they shoot up, or they do their eating, their binging, and then they feel a little bit guilty afterwards, and they feel like they've lost control, and then it starts all over again. The binge is often they're triggered by psychosocial stress, and they're carried out in secret, just like any addict would, right? Any functional addict. They're typically of normal weight, though maybe overweight or obese. That's a new one to me. When I read this earlier, I thought they were thin too, but not as thin as anorexics. And here we go. Dental enamel erosion. more aware of and remorseful about behavior than those with anorexia nervosa. How do they diagnose it? Well, so they there's recurrent binge eating at least twice a week, all right, for 3 months, and there's recurrent inappropriate compensatory behavior, right, and then self-evaluation unduly influenced by body shape and weight concerns. During the interview, they may say that to you. How do they treat it? CBT, right, involving weekly sessions for a given period of time for the treatment plan. And they get into nutritional advice and regular flexible pattern of eating. So then they have interpersonal psychotherapy, which emphasizes helping identify and alter current interpersonal problems. Okay, SSRIs have been shown to reduce the frequency of binge eating and vomiting. Major depression. Okay, it's kind of like what a lot of people are going through right now, this COVID-19, right? Characterized by sadness, severe enough to, or persistent enough to interfere with function, and often by decreased interest in pleasure activities that were previously pleasurable. All right, these people feel worthless, self-loathing, and this is distinguished from grief, right? That accompanies major loss. So, yeah, I mean, a lot of the financial stuff that's going on, natural disasters like we're going through right now, whether it's natural or man-made, still yet to be determined. What's going on here? This whole country is going through some type of financial calamity. See, here we go. Signs and symptoms. So they have these painful facial expressions, tearful eyes, furrowed brows, slumped posture, right? And poor eye contact. So they have thoughts of suicide and suicidal behavior, and substance abuse is common. They say here they have an increased risk of cardiovascular disorders, myocardial infarctions, and strokes. They say that too because these folks are eating more, right? And they're eating, they're just kind of binge eating and sitting on the couch, and they're not very active because they're depressed. They just want to stay there, and as a result, their body shows it, right? So it's going to go ahead, and it kind of makes sense, right? If you're sitting there like a couch potato, not doing anything, depressed in your own, sorrows and things like that, you're going to be susceptible to these, cardiovascular disorders. How do they diagnose it? It's presence of either depressed mood most of the day or markedly diminished interest or pleasure in almost all activities. So these people don't want to do anything, right? So they have some significant weight gain. They're either insomnia or hypersomnia, and hypersomnia, right? They just want to continue to sleep, or they stay up all night. Psychomotor agitation, or as a result of their insomnia, during the daytime they sleep, and that's quite common with insomniacs. Is they'll take naps during the daytime to catch up, right? Their body finally just quits on them, right? And they finally fall asleep. So it's kind of nice to give in once in a while, right? Give in to what your body needs. So psychomotor agitation or retardation is actually observed by others, but not self-reported. These patients won't tell you they have this type of agitation. So they have fatigue or loss of energy, and they have inappropriate guilt. Yeah, and they're indecisive, right? So they have recurrent thoughts of death or suicide. So one thing that you got to remember, if someone has a plan or they have thoughts of suicide, is that reportable? Yeah, we got to report that. As practitioners, we need to report that. So, yep, major depression continued. How do we treat it? Well, if it's mild, treated with general support and psychotherapy, education, right? Moderate to severe with drugs. We use psychotherapy or both. SSRIs are pretty common with all of these, even mild and severe. So SSRIs are the initial drug of choice. But sometimes this is what the VA gets mixed up in. Well, all of these psychiatrists, polypharmacies used. I knew some guys that had like bags of drugs, and they would just be, given, and some of them would produce side effects, and then they would have drugs to combat those side effects, and it's just not a good, good treatment plan, you know. So if we can use, herbs, longu muli added to, some chai hu formulas, I mean, these are pretty good, right? And it just depends on their constitution, what's going on that day. But I like to use some longu muli, helps them chill out at night and helps them get sleep. Um, Severe with electroconvulsive therapy, yeah, so these big machines, right? So if they have some type of psychotic depression, suicidal behavior, delusional depression, they use electroconvulsive therapy. So, hey, not far from our E-stem machines, you know. So inpatient treatment with significant suicidal ideation. So they have some type of ideation, harm to self, and sometimes when they do this, we can call the police and actually have them taken away for 3 days of evaluation due to a welfare and institutions code called 5150. So that's a California code. They call it a green sheet. When I was on my ride-alongs or my to get my hours for my paramedic, yeah, we'd call the cops all the time on folks that you know they just were in no shape to care for themselves or others. And it's unfortunate, but a lot of them were drug addicts, but it was psychosis induced by drugs, or they didn't have enough drugs, and they were going into withdrawal symptoms. And at that point, they'll do anything. They'll smash things, they'll lose their temper, they'll hurt themselves or others. And we had no other choice as medical providers, to get these people seen. Oftentimes, it helps them because when they go into 3 days of evaluation, they clean out. They're able to rid themselves of all those toxins, and it's not pretty for them, and it's not a pleasant experience for them, but it's actually better for them in a lot of cases, because they're able to dry out, right, and to get clean. So what happens after that? What's the cause of all that? Who knows? But and you have bipolar disorder, which is episodes of mania and depression, which usually alternate to some degree, but have a predominance of one or the other. All right. So teens to 30s, where it starts, there's a strong family history component, involved with that, with stress, and lifetime incidence of suicide is 15 times greater than the general population. Wow, that's a good stat, right? To know bipolar disorder. This is a lot of folks that have spouses, and that my husband bipolar. They'll come to see you. How do I deal with it? A lot of it's patient education, right? It's telling whether your patient, yeah, this is how you would deal with it. Get this book, get that book, and there's a lot of books out there on how to deal with both the borderline personality disorder and bipolar disorder. They're different, and they have different signs and symptoms. So how do we continue from here? We're going to talk about signs and symptoms. It begins with the acute phase, repeating course of remission, then relapse, right? So the mania is greater than a week of persistently elevated, expansive, or irritable mood, and persistently increased goal-directed activity, or energy plus 3 or more of these symptoms down here. So these people have grandiosity, an inflated self-esteem, so they don't need to sleep. They talk more than usual, flighty ideas, distractibility. Their increased goal-directed activity, and have an excessive involvement in activities with high potential for painful consequences, like foolish business investments, buying sprees. And I just went out and bought a bunch of stuff just now. Just kidding. Yeah, you got to wonder, about folks like this. Is it normal behavior? Is this person just driven, or does this person have bipolar? You never know. It might be both, right? So they can be driven and have these these signs and symptoms. Um, they also have depression. So features of typical major depression must include five or more in the same 2 week period. All right, and depressed mood most of the day. So they're going to have weight gain or loss or decreased or increased appetite. They're going to have insomnia or hypersomnia we talked about before. Psychomotor agitation or retardation observed by others, not self-reported. All right. So kind of the same as last disorder. And they have recurrent thoughts of death or suicide. So diagnosis is based on identification of symptoms of mania and depression, plus a history of remission and relapse. How do they treat it? They treat it with drug therapy, mood stabilizers, lithium. Lithium has significant side effects, so be careful. Um, Physicians should be careful with that, right? So they need support and psychotherapy. So in Chinese medicine, we use a lot of different treatments like external dragon treatments, 8 extraordinary meridian treatments. We can use the ghost points. There's a lot of Hun and Po treatments, Do 20, Yin Tong, ear acupuncture, auricular, different points in the auricular to help them. You know, some of these disorders are caused by organ dysfunction and other disorders, and these are all secondary to physical ailments that are happening within the body. And we can fix a lot of that. We sure can, right? Schizophrenia, characterized by psychosis and a loss of contact with reality. These people are just not there, right? They're having delusions, hallucinations, they're disorganized speech and behavior, flattened affect. And the average age of onset is early to mid 20s. It's higher and lower in socioeconomic groups in urban areas and among single people. Single people are lonely, drives them crazy. Some of them. Some people like to be alone. 20% attempt suicide. That's a lot. It's 1 out of 5, right? And life expectancy in schizophrenics are reduced by 10 years. So they have a pre-morbid stage and a prodromal phase, right? And they have a middle phase and a late phase. Pre-morbid is impaired social competence, mild cognitive disorganization. The prodromal phase is withdrawal and isolation. They kind of know what's going to happen. They start to have their delusions and hallucinations, and they're knowing they're going to go into some type of phase of schizophrenia. So, just like someone before they have a migraine headache, they have a prodromal phase, right? They have some type of aura that shows up. Well, with schizophrenics, they have not an aura, but they start to get a little irritable, they get paranoid, and they even ask their friends, is something wrong with me? Am I just thinking this or what's going on? They start to have delusions. So that's their prodromal phase. Middle phase is they have symptomatic periods, episodic or continuous, and their function deteriorates. In the late phase, they're just not there. Either the middle phase or late phase. You can see those people walking down the street and they're talking to themselves. They're just not there. No matter what you input into them, they're on a mission to just hallucinate and have all these distorted views, and there's no way that you can capture them. you know so this is the 5150. These people need to be green sheeted and psychiatric. They need to get in there. They need to get evaluated because they're able to hurt themselves or others, and you don't want those people walking around on the street. So symptom categories. The positive aspect is excess or distortion of normal function. That means they're positive, right? They have delusions, they have hallucinations. The negative is blunted affect, poverty of speech, and anhedonia, which is kind of like asexual. They don't seek pleasure at all. And disorganized symptoms, a type of positive symptom. Disorganized thinking, rambling speech, bizarre behavior. Cognitive deficits, they have impairment in attention, processing speed, working memories, problem solving, and understanding social interactions. So this is how it's diagnosed. You have greater or equal to 2 characteristic symptoms of delusions, hallucinations, and the rest here we've talked about. And symptoms must include at least one of the first 3. So delusions, hallucinations, and disorganized speech. The prodromal or attenuated signs of illness with social, occupational, self-care impairments. Evidence for a 6-month period that includes 1 month of active symptoms of the above. Factors associated with a good prognosis. You have good pre-morbid functioning, good student, strong work history. So these are a good prognosis. It's a late or sudden onset of illness rather than, experiencing all the way from childhood. So those people are actually poor prognosis. Family history of mood disorders other than schizophrenia. So, so they're saying that, schizophrenia doesn't run in the family, but they have something else that might have a good prognosis. Minimal cognitive impairment, few negative symptoms, shorter duration of untreated psychosis. So the factors associated with poor prognosis, again, opposite of late, right? Young age. There you go. If you're affected at a young age, it's very poor for you to get out of this schizophrenia. Poor premorbid functioning. So poor premorbid functioning would be like, so let's say if a veteran, right, let's just use a sample of a veteran, goes into the service and gets exposed to all kinds of things that you're not supposed to see. Well, if they had some type of pre-existing condition, like he was an inner city youth exposed to gunshots, this and that at a younger age, he already had PTSD, and so those are your premorbid functioning. Or he may have something unrelated to PTSD, and then he went into the service and experienced all these things, experienced a lot of trauma, and experienced, in a heightened awareness all the time, on alert. Yeah, then these premorbid functionings of his childhood exacerbated or caused another disorder. So family history of schizophrenia, bad, right? And many negative symptoms. Okay, I don't know what that slide means, but we'll go with it. Longer duration of untreated psychosis. That's a good point, right? So treatment, how do we treat it? So early treatment leads to better and quicker response. They use antipsychotics. This can cause tardive dyskinesia. So that's when they start like chomping on their lips and, they have some like Parkinsonian symptoms. They'll be tremoring and stuff like that, but they're always messing with their lips and doing some weird thing. And that's what happens with these side effects of these antipsychotics. Rehabilitation and community support services, psychotherapy, develop a collaborative relationship between patients, family members, and physician. So I would say physicians, because not everybody is so qualified that they're able to handle these. There's actually a team, and that includes us. We can help with this. Not so much in the latter stages, but we can help with the early stages of this. And we need to understand and manage the illness, adhere to drug regimen, and handle stress. Suicidal behavior. So it includes 3 types of acts: completed suicide, attempted suicide, and non-suicidal self-injury. So it's more common in men than females, 4-to-1. So 45 to 64 years old, that's the highest rate. I fall within that category. However, I don't have any suicidal thoughts. But, I know a lot of folks that have, and, there's this whole 22 a day, right? So you've seen people do push-ups on Facebook, and there's a lot of folks committing suicide. We need to stop that. I know there's a higher suicide rate now than there was before COVID, so, we need to work on this. The primary risk factor is depression. The other risks involve a lot of other financial, traumatic experiences, alcohol and drug abuse, and so on. Prevention requires identifying at-risk people and initiating interventions right away. So all depressed patients should be questioned about suicidal ideation. And emergency psychiatric aid for suicidal people includes the following. So you got to establish a relationship, right? Open communication. You got to inquire about current and past psychiatric care, drugs especially, right? Find out what type of drugs this may be causing his suicidal thoughts. Helping sort out the problem that has caused a crisis, offering constructive help with the problem, and beginning treatment, right, with any type of underlying mental disorder too. Referring them to an appropriate place to follow up care as soon as possible, and discharging low-risk patients in the company of a loved one or a dedicated and understanding friend. You never know with these things too. You think people are cured. Next thing you know, you find out they committed suicide. You know, if a person's going to do it, he's going to do it. They're gonna follow through with it. More men do this than others. They'll act like everything's okay. A lot of them will start giving their belongings away, or they give like all these gifts away, and they start setting up their life where, I know of cases where, they had all the paperwork taken care of, and, they didn't want to, put any stress on their family, so they took care of everything prior to, and that way it was hardly any work for them. They even laid plastic out so they wouldn't, harm the house or, stuff like that. Crazy stuff, right? And they would commit suicide. It's a bad thing, man. We need to fix this. Let's talk about insomnia now. Excessive daytime sleeping. What is that? So insomnia is excessive daytime sleeping. It's difficulty falling or staying asleep, right? Excessive daytime sleepiness is a result of insomnia. Like we talked about before, it's a self-preservation mechanism, right? Your body's saying we need to go to sleep. And causes may be intrinsic, natural, or extrinsic, right? So inadequate sleep hygiene, consumption of stimulants may cause it, right? Staying up late, regular sleep-wake schedule. So acute emotional stressors can cause these sleep disturbances, right? Anticipatory anxiety about the prospect of another sleepless night, followed by a day of fatigue. So pain can cause insomnia. And of course, depression, other mental stuff going on. The treatment focuses on the cause of sleepiness. So snoring. A lot of people snore. My uncle used to snore. I was told I snored, but I recorded myself one time, and it was just I went into like a little bit of snoring, but then it stopped. So I don't think I snore that much. I think it has a lot to do with the position of your head. It says here that sound ranges from barely audible to extremely bothersome, right? And this results from an airflow, induced flutter of the soft tissues of the nasopharynx, particularly the soft palate, when muscle tone is reduced. So it's important to identify snorers. They have increased risk for obstructive sleep apnea, which could be dangerous because you're not getting enough oxygen to the brain. If apnea is strongly suspected, a sleep study is indicated. So older age, obesity, these are all risk factors, right? Alcohol, right? Male sex, a small or posteriorly displaced jaw. Okay, you have a functional, the actual structural cause. And if you have postmenopausal status, so more blacks and whites, pregnancy, and family history of snoring. Treatment of uncomplicated snoring, avoid alcohol and sedating drugs. Sleeping with a head elevated. So this is, those wedges that you can put, those perfectly shaped pillows, right? So preventing that functional aspect of the nasopharynx, allow it to stay in a neutral position. Losing weight helps. Using earplugs. I didn't know using earplugs would help with your own snoring. I would say it would help your partner from not hearing your ass as you're, snoring your butt off, there. But what do you know? Maybe that helps. Implementing alternate sleeping arrangements like separate rooms. Okay, get the hell out of here. I don't want you snoring in my face anymore. Please leave. Go sleep on the couch, honey. Yeah, that's another one, right? Treating any nasal congestion with decongestant and or corticosteroid sprays. Okay. So now we have our obstructive sleep apnea, which is episodes of partial and complete closure of the upper airway that occur during sleep and lead to breathing cessation. Breathing cessation. Risk factors is obesity, prominent tonsils, increased neck circumference, family history, hypothyroidism, right? That's hypothyroidism. For extra credit, I want you to um, tell me about T3 and T4 and tell me about TSH as related to hypothyroidism. And also tell me what diseases accompany hypothyroidism. So anybody want extra credit? You want another, point or two? If you got like a B, you want to move it to an A minus. Hit it up. Give me a report on that. I'll help you out. Increases risk of hypertension, stroke, diabetes, GERD, heart failure, and arrhythmias. Obstructive sleep apnea, signs and symptoms, snoring in 85% of the patients. They got choking, gasping, snorting. There's some Chinese diagnosis where it says that people are snorting like a pig or like a goat or something like that. I forgot what book it's in. I think it's in the diagnosis book. I'll find it and send it to you. I think it's pretty funny. So there's unrefreshing sleep. Most patients aren't aware, but are informed by bed partners. Pardon the typo there. Hypersomnolence. Hypersomnolence. Yep. Yeah, they're going to have hypersomnolence because they're tired. And so their body is quitting on them and saying, you're going to sleep right now during the daytime. Fatigue, impaired concentration, and age over 65. How do they diagnose it? Well, they diagnose it with a couple things. It's suspected in patients with identifiable risk factors, right? Symptoms are both. They have daytime sleepiness, unintentional sleep episodes, unrefreshing sleep fatigue. They're awakening with breath holding, gasping, choking. And usually the bed partner reports it, right? They're saying this person is like not right and this person needs to be fixed. So it's confirmed with a polysomnography, including continuous measurement of breathing effort, airflow, oxygen saturation, and sleep architecture. So oxygen saturation is very important. If this person's pulse ox is down in the low numbers, we need to actually fix this, right? So they treat it with they control risk factors, the obesity and the alcohol use, and they have the CPAP. All right, the CPAP machine is, you know, uh, really good for this. So it's constant positive pressure. For me, I would have a hard time wearing it because I could hear the machine. It wouldn't work well for me. So failures are common because of limited adherence, right, to the CPAP, and that's me right there. They can surgically correct the airway obstruction, and this is what we talked about today. Thank you for paying attention. And we need to get on. I sent you guys a jot form to fill out in regards to your presentation. Please do so. Get that to me. It allows me to look at one Excel spreadsheet. So when you guys press submit on that form, I can query for dates, I can query for that, but I don't like looking at, you know, 3 or 4 different places for your stuff. Some put it on Slack, some emailed me, some used, Empower, not Empower, what we're using now, Neo. Some emailed me to my ACCH account, some emailed me Yahoo account. So now I have, 11 students here, 15 students here, and it's a lot of information to decipher. So that form, if you can help me out, just press submit, put that information on there, and I'll start to deconflict those dates and assign. For those of you that don't know what your assignment is yet, remember you have to do a 20-minute. You have to do a 20-minute presentation as a gift to the class on your disorder, right? You pick a disorder, you brief it on it. I sent you a template. I sent you a rubric. Please do the assignment. Get ready. For those that want to present today, you can present today, or you can present. Pardon me. You can present next week. Um, next Tuesday. Let me know, or else I'm going to start filling those slots. Okay. So everyone should be done with their assignment. Everyone should be pretty close, right? So this shouldn't be something that you're last minute doing. We've been talking about this for a long time. So I give you guys credit for hanging in there, and that's about it. Let me quit this recording. You have a good day.